Okay, so my topic is going to be acute pelvic pain. And so my objective is to discuss the differential diagnosis in women with acute pelvic pain. It's a very big topic. So the first assumption is that pregnancy has been excluded. So they're negative HCG, and these are usually all young women of reproductive age. So they're premenopausal because these are the kind of women that get acute pelvic pain. And we'll assume that it's really acute, severe pelvic pain. We're not going to discuss chronic or intermittent pelvic pain. And we'll, focus on complex cases, and I'll do ultrasound with correlative imaging when it's appropriate. So by definition, acute pelvic pain is a non-cyclical abdominal pain of less than 3 months duration. It's a very important cause of patients going either to the ED or to their doctor's office, about 39% of all the visits in these circumstances. And so what is the role of imaging? First of all, pelvic ultrasound is absolutely recognized to be the first imaging modality to perform in these cases. And while the field of view is relatively narrow compared to CT or MR, the big advantage of ultrasound is that you can assess focal tenderness with your probe and see if you can, with the abnormal IDCU, reproduce the patient's symptoms. The other, by the same token, I also instruct my sonographer to always ask the patient, where does it hurt? And this case illustrates that, because if you look at this case, this patient came from a doctor's office for right upper lower quadrant pain. She has a hemorrhagic cyst, which can be very well a cause of pelvic pain. But my sonographer asked the patient where it hurts. And she said, no, it hurts kind of. And she pointed to the right lower quadrant. So we looked there, and lo and behold, here is a blind ending loop with an appendicolith, and this patient had the main cause, or the reason she needed to be managed, was not her hemorrhagic cyst, but the acute appendicitis. So this case, I think, illustrates the role of imaging in triaging patients, because really the clinical symptoms are not that specific. So the bulk of what I'm going to discuss today is ovarian and fallopian tube pathology, because these are the pathology that make the patient present with acute pelvic pain. And as John mentioned, I really like to have transabdominals. I think in the emergency department, it's dangerous if no matter what they order, you don't do a transabdominal ultrasound. And so it's really important to have a TA and a TV. Now the TA may not be beautiful. You don't have to have a full bladder. But it gives you an overview of what's going on in the pelvis. And you can see in this patient, there is a lot of complex fluid with internal echo, so blood, and probably blood clot around the uterus as well, as you can see here. And the blood extends all the way in Moissan's pouch. So we did a vaginal ultrasound. And here you can see the right ovary looks reasonably normal, but there is some amorphous material next to it. And around the left ovary, there is more amorphous material. It's hard to actually recognize the left ovary, and there is some flow, though, in the left ovary. And so we thought that, now the most important thing is go and look at the beta HCG, the HCG, right? If the HCG is positive, you're dealing with a ruptured ectopic pregnancy on the proven otherwise. She had a negative HCG. So then what is causing that? Well, we postulated she had a ruptured hemorrhagic cyst with hemoperitoneum. Because she had syncope, we also did a CT, and on the pelvic CT, you can see that there is a lot of ascites, but there is a sentinel clot sign of this hyperdense material next to the left adnexa here. The coronal just showed a large amount of pelvic fluid. And what this patient had was a hemoperitoneum caused by a ruptured hemorrhagic cyst. So she was admitted for observation, and because she remained stable, her hemoglobin remained stable, she was managed conservatively. So it's rarely this patient with ruptured hemorrhagic cyst present with significant hemoperitoneum. Not surprisingly, it's more common in patients who are on anticoagulants. And it's important to recognize this entity, because if you recognize it, many of these patients can be observed in the hospital for a day or so and be managed conservatively. Obviously, if their hemoglobin start to drop or they become hypotensive, then you'll go to surgery. So, of course, hemorrhagic cyst, a little bit of leakage of blood in a hemorrhagic cyst is probably one of the most common cause of pelvic pain. Typically, the patient will say, I had acute pain, I doubled up after running, exercise, or intercourse, and by the time they wait 2 or 3 hours in the ED and you have your pelvic ultrasound, they already feel better. And these are just typical appearance of hemorrhagic cyst, the retracting clot sign, or the reticular appearance of the complex cyst with not inside blood, but just peripheral blood flow. So let's talk about this case. This is a 25-year-old woman with sudden onset of severe left lower quadrant pain. And so if you look at her, I'm just showing you the endovaginal ultrasound. So she has normal ovaries, normal flow in the left ovary. There was also normal flow in the right ovary, but just pay attention to this structure here. And then in addition to her ovary, she had this complex cystic structure in the pelvis, which was separate from the ovary. The patient was exquisitely tender over this area. So let's look on this clip. That's what's going on. And you can see that next to the ovary, there is this swirling sign here leading to the mass. And so it is a twisted pedicle. Now, in this case, because we know that the ovaries are normal, this is not twisted ovarian torsion, but it's isolated torsion of a fallopian tube that was actually proven at surgery. So isolated tubal torsion is a rare entity that's often misdiagnosed because we see both ovaries with flow, and so we don't quite think about this entity. Predisposing factors are hydro or hematosalpinx, peritubular ovarian cysts that may act as a lead point for the torsion, adhesions, and the ultrasound findings that were just as described. Normal ovaries, usually a cystic mass separate from the ovaries, the patient's focally tender, and look as much as you can for a thick fallopian tube or ideally the whorl sign of the twisted pedicle. This is a much more classic example of a 40-year-old who presented with lower abdominal pain, nausea, and vomiting. Classic example of ovarian torsion. So she's a very large mass. And again, this again shows how the TA is so helpful. It's a very, very large mass, 12 centimeter with, echogenic area shadowing. This is a classic example of a dermoid, right? But the dermoid is sitting on top of the uterus. And again, the patient presents with abdominal pain, nausea, and vomiting. So we're suspecting torsion, and we try to prove it by going from the mass to the uterus in the broad ligament, and we find here the twisted pedicle again. And this is just a still image showing that thickened, twisted pedicle. Something important is anytime a woman has pain and nausea, not just pain, but nausea, I really have to at least think about the possibility she could have torsion. So this was the patient's surgical specimen. So what happens is that when there is twisting of the ovarian suspensorial ligament, and depending on the degree of torsion, you have compression of the ovarian vein and lymphatics. So you have edema of the ovaries and enlargement. So I don't really diagnose ovarian torsion unless the ovary is enlarged. And then eventually you can have arterial ischemia, hemorrhage, and infarction. And this was basically the infarcted dermoid with also the infarcted ovarian parenchyma surrounding it. So what are the ultrasound findings in ovarian torsion? So you always have to have an enlarged heterogeneous ovary. Because of this edema, you'll have increased echogenicity and size of the ovarian stroma. The follicles are pushed to the side, and they often have this echogenic rim, probably because of the edema. You may or may not see a mass. So this particular patient here did not have a mass. Also think about ovarian torsion if the ovary is in an unusual position, either in the cul-de-sac or flipped over the uterus. Try to do or instruct your sonographer to look for the twisted pedicle, which has a target or whirlpool sign. Exquisite focal tenderness is an additional very useful findings. And the important thing is to remember is that Doppler findings are variable. So this particular patient here, in this case of ovarian torsion, did not have any flow. This is just artifact from the power Doppler, which is very sensitive to motion. But in this next case, the people who originally saw this case in an outside hospital were confused because there was flow. So again, if you look at this patient, and she made 3 trips to the emergency department because of pain. So she has an enlarged ovary, which on the TA, you can see very quickly that the ovary is in the cul-de-sac. So that's kind of a red flag. The ovary is enlarged with increased trauma. The echogenic rim of the follicles, but this one had flow. And so they got confused and they thought maybe she had some sort of ovarian tumor because of the flow. Now she came to Hopkins and we were doing a staging CT, and she illustrates all the CT signs of ovarian torsion. It's the same patient. So again, you have an enlarged ovary, which is in an abnormal position in the cul-de-sac. There is marked diminished enhancement of the ovary. If you have a cystic mass as a lead point, you may have asymmetric thickening of the wall of the cyst. Look for deviation of the uterus towards the side of the torsion and look for the twisted pedicle. And oftentimes this patient will have ascites as well. So the twisted pedicle, here you can see it on the axial images, but sometimes it's helpful to have the coronal reconstruction. And here again it is. Just follow the gonadal vein all the way down to see if you can find the twisted pedicle. This is a different patient who has a nice example of twisted pedicle of a large ovarian dermoid, and she actually presented with right upper quadrant pain because of the location of the dermoids. So a few tips and tricks that I teach my sonographer to find the twisted pedicle. Use a TA approach. I showed you a couple of examples. If a patient is thin, you can think about using a linear 9 transducer. Sometimes you'll see things better. And this is a patient who was pregnant with twins, who was tender over the left ovary here, which was only mildly enlarged. And here again, the twisted pedicle on grayscale, going from the uterus to the ovary and with color Doppler as well. Okay, now we're going to move to this patient who is 37-year-old with acute pelvic pain, fever, and elevated white blood count. She also has cervical motion tenderness. And so we already know before looking at the case what we're suspecting, right? So here she has a tubular structure with an echogenic hyperemic wall with color Doppler. The tube this entity is filled with low-level echoes, which look like pus or blood. And she also has very complex ascites. And so this is a good appearance for a pyosalpinx. And so, of course, pelvic inflammatory disease is probably one of the most common cause of acute lower abdominal pain in young women. Most of these women are young and sexually active because this is a sexually transmitted ascending infection, usually with chlamydia, GC, or polymicrobial infection. And we all know about the risk factors, right? However, occasionally there are other infectious etiology, much less common, tuberculosis, which is hematogenous spread, actinomycosis, which is kind of a smoldering, low-grade infection. Patients who have an indwelling IUD for a long time are at risk for that. And then you can have pelvic abscesses not really related to GYN etiology, but they're still sitting in the pelvis. And it can happen from direct spread from a GI source, such as appendicitis or inflammatory bowel disease or diverticulitis. So what are the findings in pelvic inflammatory disease? Well, if the disease is mild, you may see almost nothing or just kind of a fuzzy contour of the ovary. Or you can have the pyosalpinx that I showed you, thick wall, tubular, adnexal mass with internal debris. Or you can have, and you can still see the ovary separate, or you can have a large complex collection, which is engulfing the ovary and the tube together, the tubo-ovarian complex. So this is a classic example of pyosalpinx, tubular structure. When you see it cross-sectionally, you see the thickened echogenic wall and the thickened fimbriae due to inflammation. You put color Doppler, you have hyperemia. The other thing is look, and this is true for any inflammatory findings, look for echogenic fat, because the echogenic fat on ultrasound is the equivalent of mesenteric stranding on CT. This patient had a tubo-ovarian complex. On the right side, you still kind of recognize the tubular contour and the ovary separate, but on the left side, just basically one big complex fluid collection with thick wall and internal echoes. She had bilateral tubo-ovarian abscesses. They actually caused bowel obstruction. These are dilated bowel loops on ultrasound. And on CT, you have the typical appearance of cystic lesion with enhancing wall in the pelvis. So CT is really helpful either for complicated pelvic inflammatory disease or prior to drainage. And the CT findings are these, as I just illustrate, this case also illustrate that thick-walled, enhancing wall, tubular structures in the pelvis sometimes are best seen on multiplanar reconstructions, particularly coronal reconstruction. You can have marked stranding or fat stranding in the mesentery. You can have thickening and enhancement of the uterine ligament. And if you have anterior displacement of the broad ligament, it's one of the signs that's been described to differentiate pelvic abscess to GYN origin versus bowel. And sometimes the patient will referred right upper quadrant pain due to the right upper quadrant inflammation or Fitzgerald's. So this is a very old case. The images are ugly. I apologize, but this was a 46-year-old woman with pelvic pain and groin pain and fever. So on the transabdominal here, you see an ill-defined adnexal mass with internal echoes. When you look at the inguinal region here, you have kind of, again, this inflammatory process that's spreading into the inguinal region. And on CT, we see in the uterus a little piece of the IUD, which we didn't quite see on the ultrasound. And basically what she had in some kind of soft tissue mass or lesion, ill-defined in the pelvis with a cystic area. And basically what she had was an indwelling IUD for a very long time, and she had actinomycosis, and probably the infection spread through the ligament of Nuke into the inguinal region. Not every tubular structure in the pelvis is going to be a tube, right? So if you look at this patient here, there is a blind ending loop. You can see it here again. Now, the ovary was separate from it and was normal. So if you look carefully at this, it kind of doesn't look like a pyosalpinx because the wall is hypoechoic and the inside is echogenic. This is typical gut signature. There is a little bit of inflammation around it. So this patient has acute appendicitis. It was confirmed here on CT, but she presented with pelvic pain because the appendix was deep in the pelvis. So again, another example, and we'll find them from time to time on endovaginal ultrasound. Here's another example of a mildly thickened appendix. Notice the echogenic fat around it, which is an indication that there is inflammation as well as the hyperemia. So one of the pitfalls is to make sure you don't confuse bowel or abnormal bowel with an abnormal fallopian tube, right? So this patient overnight was called by the resident to have a pyosalpinx, but I've put a true pyosalpinx for comparison. If you look at this tubular structure, the wall is actually hypoechoic and thickened, and the inside is echogenic. So that's gut signature again. And this patient had acute diverticulitis, as was recognized again on this patient's CT. Another pitfall is this patient. So this is a 70-year-old woman with pelvic pain and fever. So first of all, she's not the best candidate to have pelvic inflammatory disease because she's older. And she has this very complex fluid collection, ill-defined border, very large amount of echogenic material. Some of it is shadowing, so it kind of looks like air. So if an abscess in the pelvis has air, it's more likely to be GI origin than GYN origin. So in this case, right away we go to CT because we can't have a clear answer on the ultrasound. And here's her diverticular abscess here, easily seen on CT with air, secondary to acute diverticulitis. This was a young woman, was not sexually active, history of Crohn's disease. So again, if you look at the transabdominal ultrasound, bilateral complex adnexal masses look just like pelvic inflammatory disease, but she was not sexually active. So that's one strike against PID. And if we look very carefully, there's these linear things that kind of look like fistulous tract. And on the CT, it confirmed that she had bilateral, yes, pelvic abscesses, but she also had a fistulous tract and more slides through that it was communicating with the small bowel. So you can also have pelvic abscesses in Crohn's disease, inflammatory bowel disease. Okay, let me move on to the next case. This is a 44-year-old woman who presented with severe abdominal pain, and she said she had several episodes like that. So because her pain was so severe, they started with a CT scan, and you can see there are bilateral pelvic masses. Now, this mass has a very thick wall, and there is a lot of inflammation of fat stranding just anterior to this mass. A little bit of complex ascites. So then she had an ultrasound, and on ultrasound, we said, well, this looks like an endometrioma, right? And we'll go on Wednesday why it is, but diffuse low-level echoes, little echogenic foci in the wall. That's typical appearance for endometriomas. Now, endometriomas usually don't twist because they're adhesions. So we still couldn't figure out why she had so much pain. She was very tender over this area, though. So we thought possibility of torsion. That's unusual with endometriosis. And so she had an MR. Again, the MR shows the same thing. It confirms that these are endometriomas. There is a nice T2 shading in the smaller lesion, thick wall, and very intense inflammatory reaction around this large mass. So we said it's either torsion or possibly rupture of the endometrioma. And at surgery, it turned out she had ruptured endometrioma with adhesions. So this is an uncommon complication of endometriosis, supposedly more common in pregnancy. Patients will have severe pain because of the chemical peritonitis of leaking blood products in the peritoneal cavity. So it will mimic ovarian torsion clinically. The patient will have to think about if there is endometrioma, ascites, and this intense inflammatory reaction. Also look for thick wall. Look for wall discontinuity that you can obviously better appreciate on CT with contrast or MR with contrast, and the fat infiltration. So in fact, although endometriosis is a cause of chronic pelvic pain, we don't think about it as acute pelvic pain, but there are circumstances where it can present acutely. And if there is an acute abdomen in a young woman, that's at least this entity, you need to think about it. You'll be lucky if the patient has a history of endometriosis or chronic pain of infertility. If you see cystic masses in the pelvis, in addition to whatever it is that's causing her to present acutely, and I'll show you a couple of cases. But you know that endometriosis can obstruct the distal small bowel, the sigmoid colon, or the distal ureters. So let's just look at a couple of examples. This is a patient who had recurrent abdominal pain. She had multiple visits to the emergency department. This time she presented with small bowel obstruction. She also has right hydronephosis with delayed enhancement of the kidney here. And she has this sort of ugly looking hyper-enhancing mass in the pelvis, has an infiltrative appearance. So for the word, it looks like a cancer, right? So on the MR, same thing, but and it's enhancing on MR, but because she was a young woman, we at least raised the possibility that could be endometriosis. And that's what she had. She had extensive endometriosis involving the terminal ileum and the cecum. Another example, a woman who presented with groin pain, again, groin mass, acutely tender. And if you're astute and ask the patient, does it hurt more with your period, cyclical pain, that should be a clue that this could be endometriosis. Or here's her mass, groin mass enhancing on CT. And on MR, you can see that there is very mild but recognized dilatation of the distal left ureter. Here's her inguinal mass, but she also has dark on T2, this infiltrative deep pelvic endometriosis. And if you tie everything together, again, this is pelvic endometriosis as well. So just that's something to think about in a young woman. Now, this is a 39-year-old woman with abdominal pain and abdominal distension. So we all can recognize that she has bilateral enlarged ovaries with multiple cystic spaces and ascites. If you ask her the appropriate questions, she'll say, yes, I'm being treated for infertility, and this is hyperstimulation syndrome. So just a quick word about hyperstimulation syndrome. It's usually iatrogenic. The history is usually infertility. Patients with polycystic ovarian syndrome are at higher risks. And they can get into trouble because of third spacing of fluid and electrolyte imbalance. So typical ultrasound appearance will be enlarged ovaries with multiple cysts, and they can have ascites and pleural effusions as well. And of course, there is an increased risk of ovarian torsion because of the large size of the ovaries. Now, to finish, I'll talk about uterine pathology. So it's a much less common cause of pelvic pain. Usually they present, as John showed beautifully in his lectures, with vaginal bleeding. But you may have pelvic pain if there is distension of the endometrial cavity with blood, either in congenital abnormality, for example, in perforate hymen, or in patients who have obstruction of the cervix due to stenosis or synechia. And the other thing is, while fibroid or myomas rarely are symptomatic, at least not with pain, there are a couple of instances where they can cause pain if there is torsion, for example. So let's look at a couple of examples. This is a classic example of Asherman syndrome. This patient had local cyclical lower pelvic pain. She had a history of endometrial ablation, and this caused synechia, and now she cannot evacuate her menstrual blood, and so there is recurrent blood in the endometrium that end up distending the endometrium. You can see it in ultrasound and in CT as well, and that is the cause of her pelvic pain. Degenerated myoma can do this. This patient had back pain. It's really hard to make a diagnosis really on ultrasound because they don't always look cystic. Now, this is an interesting case. So this patient with worsening pain and pressure, and she has on the transabdominal, you can see here's the uterus, and there's this big sort of hypoechoic mass. Again, you can see it in the cul-de-sac, and we saw both ovaries separate from it. So on the CT, sorry, next slide, you see the CT just basically shows the same thing. And, you know, this doesn't look like a typical fibroid, right? Because it should enhance much more homogeneously. So there are some areas of necrosis. On MR, what is very helpful is that you clearly, again, verify that it's separate from the ovaries. And so our differential diagnosis was whether it's a towards fibroma or a towards fibroid. But my MR colleague very astutely picked up that there is a little communication between the myometrium and this infarcted hypoenhancing mass. And so they made the diagnosis of necrotic fibroid likely due to torsion. And so to finish, just, again, no tunnel vision, just look around. This is another patient who came for pelvic pain, left-sided pelvic pain. Her ovaries, uterus was normal, but if you look carefully here, you see this linear hypoechoic structure with two little shadowing calculi. And so this ties this talk to Linda's talk, and you can really see the distal ureter nicely on endovaginal ultrasound. You can see the shadowing much better. So my take-home points is with ultrasound, you really, because it's a narrow field of view, you want to make sure you evaluate the right area. The requisition may not always be right, and correlate the ultrasound finding with the patient's symptoms. That's probably the greatest strength of ultrasound, is that by pushing on whatever is abnormal, you can reproduce the patient's symptoms. Remember, the presence of ovarian flow does not exclude ovarian torsion. And in the ED, I highly, highly, highly recommend that you do transabdominal as well as transvaginal ultrasound. And if ultrasound doesn't provide the answer, then go to MR or CT in patients, particularly if the patient has significant symptoms. Now, by the flip side, if you start with a CT and the CT is normal, I don't think this patient should have pelvic ultrasound just to confirm that the CT is normal. A normal CT will exclude any significant ovarian pathology. And with that, I thank you for your attention.